My name is Hilary Robbins, and I'm an epidemiologist at the International Agency for Research on Cancer, which is the specialized cancer research agency of the World Health Organization in Lyon, France. So the abstract that I have presented at the World Conference on Lung Cancer, this one is about the performance of lung cancer risk prediction models and cohorts in the UK population. So this is of interest in particular because lung cancer risk prediction models are increasingly being used to define who is eligible for lung cancer screening. So whereas the USA has used categorical criteria, for example, age 55 to 80, more than 30 pack years, less than 15 quit years, the UK has taken a different approach to try to increase the efficiency of screening programs, which is to use risk prediction models to decide who is eligible. So you can apply these models to predict someone's individual risk based on their specific age, their specific smoking history, and the specific comorbidities that they might have, for example, COPD. And you'll get a numerical risk prediction, for example, 2% risk over 6 years. And there's a threshold set for screening. And if your risk is above the threshold, then you can be offered screening. So this is basically the idea. However, if risk models perform poorly, then it can in fact lead to very inefficient screening programs and can miss people who should be eligible, who have high risk, and also include people who should be excluded because they have low risk. So it's in fact quite important to evaluate the performance of models based on the populations where you intend to implement them. Most of the risk prediction models were developed in US data and have subsequently been applied sometimes in other populations. These include the lung cancer death risk assessment tool, the lung cancer risk assessment tool, and the PLCOm2012 model, notably, as well as the Bach model. There's also a group of models developed in the Liverpool lung project. So these obviously were developed in Liverpool in the UK, and these are UK-based models. The Targeted Lung Health Checks program in the UK has defined eligibility based on two of these models, both the PLCOm2012 model and the Liverpool Lung Project version 2. These are the models included in the protocol that you can use to decide who is eligible and who is not. But our goal was to evaluate the performance of these and other models, specifically in the UK population, because the evaluations done to date have not actually been in the UK. So we analyzed data from 3 cohort studies, the UK Biobank, which is about 200,000 people, the Generation study, about 26,000, these are women, and the UK portion of the EPIC study, which is about 30,000 people. And we quantified whether the models predict the correct number of cases and whether they can discriminate between future cases and future non-cases, people who will not and will develop lung cancer. So what we found was that in the UK Biobank, which was the largest study population, the discrimination was highest for the lung cancer death risk assessment tool and the lung cancer risk assessment tool, followed by the Bach model very closely. All of the models predicted more cases than observed, but we think that this is probably due, at least in part, to healthy volunteer effects in these cohorts, where people that volunteer to participate in research cohorts are healthier than the general population, which would be expected to produce apparent overestimation of risk. So this may not really be a finding that's generalizable to the general UK population. In order to compare the models sort of head to head, we combined the 3 cohorts, the 3 study populations into one, and found a threshold for each model that would screen the same number of people as the US Preventive Services Task Force criteria. So if each model were going to screen the same number of people, we find the threshold for that model that would screen that number of people. And then we say, okay, if each model is allowed to screen the same number of people, which one of the models captures the most future lung cancer cases into the population that is defined to be screened? Because this is a way to get at how efficient screening would be under each different model. So what we found is that the highest proportion of future cases was identified by the lung cancer death risk assessment tool and the lung cancer risk assessment tool, both of them 60.9% of future cases, followed closely by the PLCOm2012 model, 58%, as well as the Bach model, 58%. Whereas the LLPv3 was a bit lower, 56.6%, and the LLPv2 was only 53.7%. So what we saw, and the USPSTF criteria, by the way, identified 50.7%. So all of the risk models seem to be doing better than the categorical criteria. But the models do have some important differences between them. So our conclusion is that the ability of these models does vary in the UK population. And it appears to be best for the lung cancer risk assessment tool and death risk assessment tool, followed closely by PLCOm2012, but is less good for the LLPv2 model. So it's possible that by specifying use of PLCOm2012 and LLPv2, the NHS protocol might be missing an opportunity to use risk models that discriminate a bit better in the UK population. And overall, what this illustrates is sort of the importance of validating risk prediction models in specific contexts, preferably before, but at least in conjunction with their implementation.